You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
King Lee is the inaugural Dean of the Carle, Illinois College of Medicine and Chief Medical Officer for the Carle Health System. The Carle, Illinois College of Medicine is an initiative of the University of Illinois at Urbana-Champaign and Carle Health System. Dr. Lee's undergraduate education as well as his medical degree are from the University of Toronto, and he earned an MBA from San Jose State University. Dr. Lee held leadership roles at the National Institutes of Health Clinical Center, Stanford University, and Houston Methodist Hospital. Most immediately prior to his current appointment, he was Senior Associate Dean of Medicine for Clinical and Translational Research at Wake Forest University and a Deputy Director of the university's Cancer Center. Dr. Lee, help us launch today's discussion by telling us what makes this new medical college so much of a departure from conventional schools of medicine.
I think the answer to both questions is resounding yes. The idea of how we actually deploy technology in healthcare is actually a very interesting one.
Yes.
So we have seen tremendous advances in the deployment of technology in healthcare. However, there are also areas where technology hasn't infiltrated. For example, if you go to a doctor's office today, look at the tools that they use as compared to 30 years ago. You'll find that they haven't changed dramatically.
Not very much.
Right. Imagine the stethoscope that was actually discovered in about 200 years ago. And the otoscope, the instrument that doctors use to look into patients' ears, it was discovered about 180 years ago. So those technologies, right, are really low fidelity and low efficiency. Let's take the stethoscope as an example. It actually ties in data acquisition, data analysis, and also decision making and counseling, all to the highest paid person in the healthcare food chain. So that's very inefficient. And the human ear is really not a very high fidelity, device for recording sound. So imagine you can actually divide it up into different steps. Use a digital stethoscope that can record sound with much higher fidelity than a human ear. Use artificial intelligence to analyze the waveforms, which is better than any single doctor, and then give the decision support to the doctors, and then doctors can then help make the decision and then counsel the patients. And the power of this is the data acquisition and analysis can be done remotely, and the doctor doesn't really need to be involved in that process, so the cost is actually lower. You can imagine using technology then to increase the healthcare quality, decrease cost, increase accessibility, and increase equity.
Would it be fair to say there's a sort of sorting out or a division of labor that ultimately not only improves quality of care, but improves efficiency?
Yes, absolutely. You can increase quality, increase efficiency, decrease costs. At the same time, right, we can deal with the physician shortages that we are facing these days.
That leads me to ask, what will the patient experience in a world that where his or her physician is someone who's been trained at your particular college? How different will their environment be?
The environment will be actually more humanistic. So imagine the physicians not spending time dealing with just entering data into the patient records, but actually spending more time listening to the patient and actually discussing potential treatment plans in a more personal manner. The actual major difference in the future is actually the way we gather data about the person that we're dealing with. So currently, if you walk into a doctor's office, the first thing they ask you is about so-called major complaint. What are you complaining about? All right, this is dealing with treatment rather than prevention. Imagine the day that the doctor knows you as a person, and then they're trying to actually institute preventive measures so that you actually don't develop the disease later on. And that data doesn't come from taking your blood pressure or measuring your blood sugar, because those are so-called late biomarkers. By the time your blood pressure is already high, it's late, right? You want to capture the potential problem before the blood pressure goes up to be abnormal. And that data doesn't come from measuring your blood pressure, but actually looking at your family history, looking at your genes, looking at your behavior, like what type of food you're eating, do you exercise, and so on. And that type of data can be gathered a lot more efficiently these days.
In terms of change, then, we're seeing a change that not only talks about a different division of labor and a shifting of responsibilities for varied tasks, to a really change in the focus of care that moves away from simply treating the injury or trying to heal the disease to actually preventing those phenomena.
Absolutely. So there's also a fundamental shift in the understanding of what modern medicine represents, right? If you think about it, the major breakthrough in modern medicine is actually in dealing with infectious diseases. So imagine you can isolate a microorganism that causes a disease, use the correct antibiotic, and you actually cure, right, the infectious disease. And that becomes essentially the model of how both practitioners and also patients think about healthcare today. If you have obesity, you want a doctor to give you a pill, right? And then you don't have to deal with it, right? You're cured. But that actually doesn't happen in most of the diseases that we deal with today. If you look at the so-called models of disease, the first category is the so-called deterministic model. That means that there's a cause and an effect. If I hit you with a car traveling at 500 miles per hour, I know exactly, right, you will be injured big time or be killed. So that's deterministic. Whereas most of the diseases like diabetes, like cardiovascular disease, those are so-called stochastic diseases. They're dealing with not certainty, but risks. For example, not everyone who smokes would have lung cancer, but the risk goes up if you smoke. On the flip side, some patients who develop lung cancer never smoke, right? So it's just a risk adjustment. So to deal with stochastic models of diseases, you're really dealing with adjustment of a lot of factors, including lifestyle, to prevent the disease better than actually treating the disease later on.
One of your colleagues, Philip Payne at Washington University, likes to tell the story about the fact that 80% of the health dollar is tied up in dealing with chronic diseases, which are primarily a matter of lifestyle choice. And what you're suggesting is that by recognizing that there is a probabilistic element to what those behaviors and lifestyle choices mean, we have a much more, if you will, rational allocation of how we use our healthcare dollars to deal with them.
Or not use healthcare dollars at all, right? So imagine you're actually changing social behavior. So part of our curriculum is teaching our students how to change a person's behavior. And typically, if you ask me, the best people who do it well is actually not doctors, right? Those are actually the marketing people. Imagine what beer you drink, what shoes you wear, right, has a lot of influence. The marketing people actually influence us in a big way, right? So, in fact, in our college, we are leveraging the expertise in other colleges, social psychologists, marketing people, and so on, to help teach our students as to how to change potential behavior in the people that they're dealing with. Similarly, right, in other parts of the curriculum, we actually leverage heavily across the campus in terms of expertise. We actually have professors from 10 different colleges teaching in our medical school.
Do they get to wear white coats? I guess is the first question I have.
Not the other professors, but our students.
Let me be a skeptic for a moment, if you will. You're talking about something that is genuinely novel in that it takes two fields or professions and brings them together and then adds still more. I know folks we've been talking about interprofessional education and the preparation of doctors for at least 35 years, at least 35. And yet, if you walk into most medical schools, those departments are still there, and woe be to the person who in any way challenges the province of one of those particular departments like cardiovascular. But now, on the other hand, engineers are criticized because if you're in civil engineering, you don't have anything to do with somebody in computer engineering, or if you're in electrical engineering, you don't want to have much to do with anybody else having to do with moving earth. So what makes you and your colleagues feel confident that the approach behind the Carle College of Medicine will produce physicians with the improved skills and abilities more so than would have been the case from a traditional medical school?
Well, I think the first thing is the mindset. If you think about it, in traditional medical school, they don't typically encourage curiosity and creativity. So we are typically trained to learn the so-called standard of practice. But our students actually, we encourage 4 qualities. We call them the 4 C's. First is compassion, because we are training doctors. Second is competence. These 2 are pretty commonplace in all medical schools. But the last 2 C's are uncommon. Those are curiosity and creativity. And for us to really ingrain this in our students, in the clinical years, in every clinical rotation, they are required to come up with a new idea. That's called idea projects before they can finish that rotation. And to help them, we actually integrated so-called engineering rounds into the curriculum. So typically medical students go to clinical rounds with clinical professors, but we also add in the engineering professors. So when the students see something they want to improve on, they can ask questions. Why are we doing this? And can we not do it the other way? And then both the clinical professors and the engineering professors will help them shape the ideas, and hopefully they can form a very well-formed idea by the end of the course. And out of all those ideas, one will be chosen to be the capstone project. They will have to turn the idea into a prototype before they can graduate. And during that time, right, in the last year that they're doing the capstone projects, they can choose from a list of students who have sign-up sheets across campus that they then form a team. They will become the leader and then use the team that may consist of students from business school, design school, engineering schools, and so on, to turn the ideas into a prototype. And to help them, we actually have formed a so-called medical maker lab network, which is a network of different fabrication facilities on campus. Because even if you have an idea, if you don't have fabrication facilities, you can't really make a prototype. So we have fabrication facilities that can make molecules to genes, to cells, to tissues, to even the electronics and 3D printing, right? So that would help them. And by the end, we will ask the students to present, not just internally, but we'll invite venture capitalists to come in, and some of this idea can turn into intellectual properties and may even move on to become companies.
That to me is the remarkable example of drawing on engineering. I've always felt that engineering had a certain power to it, precisely for what you described, telling a student, find a problem, solve it, then develop a prototype. And to see that happening in medicine is fascinating because it does, for a student, I would imagine, transform what otherwise might be a somewhat, vicarious experience into something very, very real.
Exactly, and very structured.
Let me ask you this, because I'm thinking of those very bright students that you've attracted to this program. So they've graduated. It's 2022, and they've graduated. What would you want those students to feel or think about in terms of the education and training they have? They will be aware of the fact that they've been in a very different learning experience. But what do you think they'll think about as they prepare to actually enter practice?
Okay, so the first thing that we want to make sure they understand is that they will be as competent, if not more competent, than any other medical student coming from traditional medical training when they walk into any postgraduate medical training programs.
Yes.
That means that they will excel at the traditional metrics, like the board exam scores, like how they would perform in the clinic, right? So in order to help them to do that, we actually liberally use a lot of simulation, for example. So instead of just the traditional physical simulation where you would build like a ICU, a emergency room, and you use mannequins and so on, you can actually also do simulation ultrasound, or if medical students are trained from day one using ultrasound, for example. And then we also use the second level of simulation that's called cognitive simulation, right? To actually train them to react to different clinical situations. And then the third level is called virtual reality or augmented reality simulation, where, using goggles and so on, they will be transported into the virtual environment and get trained that way. So by the time they get into the clinic, they will have to have encounter many conditions where they may not have seen the real patients, but they have seen them in simulation. So they will be very well prepared. And the main thing we want them to become is really physician innovators. They can practice good medicine like everyone else, but the main difference is they'll be innovators, so that they will actually try to change the way we practice medicine, not just to practice excellent medicine.
Is that an explicit expectation? Are the students aware that that's an expectation of them?
Yes, yes. In fact, we have T-shirts that said "Future Physician Innovators."
When it gets T-shirt status, you know it's real. I can tell.
Yes, absolutely.
Let me change gears a little bit, because there's another side to what you're doing there that I want to address. As you well know, the Association of American Medical Colleges continues to warn that in the United States, we're already beginning to experience a shortage of physicians, and that will only grow in numbers unless more is done to graduate physicians. The 32 students of your first class are 32 more than would have been produced otherwise. So that's the good news. But are there aspects of the Carle model that can scale up the number of MDs at something less than the cost of the first 32? Or is it the case that the cost of conventional medical education, even in a new environment with a new approach, are going to remain the same?
I think the major impact that we are going to make is really use technology to decrease the number of physicians required to actually provide actually top-notch healthcare, right? Just like technology, if you deploy correctly, in other industries, right, it actually increase quality and decrease cost. And that's the ultimate impact, not the cost of training the medical students, because that is very low compared to if you actually increase the efficiency so that you don't actually require that many physicians in the long run.
One more question that I have to ask. Well, two more. In some of our previous interviews with people who are doing remarkable things similar, and well, at least in some way similar to you, we've asked them whether or not the future role of technology and information and data how that will translate into the delivery of care. You know that there are forecasts of smartphones and wristwatches that are capable of providing a patient with access to more information about the patient, as well as means of helping them to represent and understand what the data mean. And all of that is probably greater than any physician could walk around in his or her head. And so in a way, it shifts the locus of knowledge, if you will, just from the physician to the patient. But that leads me to ask, I think, is a question that doesn't doubt so much what the profession of medicine is about, but it's just about human nature. And that is medicine prepared for such a fundamental change? That is, where the patient has as much access and as much data as the doctor will ever have, and perhaps more. And there will be tools that will help the patient to understand what those indicators are of his health in terms of a diagnosis and a prognosis. Is medicine as a profession ready for that kind of change?
I think people are putting too much emphasis on what artificial intelligence can do versus what a human mind can do.
Mm-hmm.
In fact, most of medical decisions are not made according to solid data and knowledge. A lot of it is actually finding the correct approach for that particular person.
Mm-hmm.
So in a stochastic model of disease, there's no definite answer. It's only probabilities, right? Even with the best data you can collect and the best knowledge you have, there will be probabilities, right? Giving the same medicine or treatment to 100 patients with the same supposed to be a stage of disease, you can have a variety of different outcomes. So the computer is not going to say, hey, this is the only treatment that's going to work, right? What is going to be is now a joint decision between the patient and a well-informed doctor to together, right, make the choice. And if the disease is not responding to the first-line treatment, then what happened, right? So that is when the doctors really can make a difference because of the experience. They have seen many patients, and also the ability to deal with the humanistic aspect of making the right choices together with the patients.
I can't help but believe that in your position, as much as the expectations are high, this must be an extraordinary opportunity for you.
Absolutely. This is, to me, the best high-impact projects I've done in my life because you can see the amplification effect. Our students can go out and become physician innovators and physician leaders. The impact would be certainly much bigger than I can do by myself. So, and they can teach more people, and this amplification effect can potentially reach all parts of the world.
Well, I said there were two more questions. I used one. The second one is it too late for me to apply for the next class? I'm only 68 years old. I have a PhD, and I have very good quantitative skills. Do you think I could be admitted?
We don't have any age limitations, right? If you have all the right qualifications and you are screened by our admissions committee to be one of the best applicants, you still have a shot.
I think actually you just said no, but that's all right.
It's a probability thing, right? What is the probability?
Would you please extend our best wishes to this entering class of medical students? And I want to thank you very, very much for what has been a delightful interview, and best of luck.
Thank you very much for the chance to reaching out to audience that we otherwise would not have the opportunity to reach out to. And thank you for your good wishes also.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.